So welcome to today's ERA Journal Club. So my name's Kate Stevens. I'm a nephrologist from Glasgow in the UK, and my co-moderator is Jennifer Lees, who is also based in Glasgow and is a consultant nephrologist. So the format today is just slightly different. We've had a couple of technical glitches. Our presenter is Kat Pinho-Gomes, who is based in London. She's a public health doctor, and we're going to discuss her paper about women's representation in clinical trials of patients with chronic kidney disease. Now, Kat isn't able to join us until a little bit later, so her presentation has been pre-recorded, so you'll see that shortly. We're delighted to have Professor Jim Burton from Leicester. So Jim is an accomplished researcher, but he has a particular interest in clinical trials. So we are delighted to have him on the panel. Prof. Levin, you will all know from Canada. Now, she unfortunately is double booked and she may be able to duck in later, but she may not be here at all. So apologies for advertising that she would be here when she is not. She's very apologetic, and I guess it does mean that poor Prof. Burton is less outnumbered than he might otherwise have been. So you'll now see Kat's presentation playing, and then we'll go to a live discussion with Jim and myself and Jim.
So my name is Kat. I'm a public health doctor and a researcher at the George Institute for Global Health, which is based at Imperial College London. And I'm here to present you the work I did with my collaborators who are named on this slide, looking at women's representation in clinical trials of patients with chronic kidney disease. The full paper has been published last year in a Clinical Kidney Journal, and you can access it on the journal website. So why do this study? Well, we have known for a long time that women are underrepresented in medical trials, clinical trials, across all medical specialties, and this has been well demonstrated, for instance, for cardiovascular disease, for stroke, and for dementia. However, for chronic kidney disease, this type of evidence was lacking. And why do we care about it? Well, we know that there are differences in CKD between women and men. For instance, more men than women undergo renal replacement therapy, and it seems that elderly women are more likely to prefer conservative care than men. And also, mortality is higher among men at all levels of pre-dialysis CKD, whereas mortality among individuals on renal replacement therapy is similar for women and men. And there is a recent study that looked at the sex differences between the effects of sodium glucose co-transported towards SGLT2 inhibitors. And that study showed that women were underrepresented in those randomized clinical trials, but it was a small study that only included 8 trials, and they were all published in the New England of Medicine. So this is unlikely to be representative of the entire population of trials with CKD, and that's why we wanted to do this study, to investigate women's representation in CKD trials and also look at whether results have been reported disaggregated by sex, both in terms of efficacy and safety. And for that, we went to the database of clinicaltrials.gov, which is the largest platform, the largest register of clinical trials in the world. And we searched for clinical trials on CKD and then restricted these to trials that included participants of both genders. Trials needed to have at least 100 participants, be phase 3 or 4, and be targeted to patients rather than healthcare professionals or carers. Trials were excluded if they were conducted in patients under the age of 18, or whether they didn't relate to treatment of CKD but related, for instance, to prevention of CKD. And we then calculated the participants to prevalence ratio. And for that, we divide the percentage of women among trial participants by the percentage of women in the underlying disease population. And that gives an estimation of the representation of women in comparison to the representation in the underlying population of patients with CKD. And this is to ensure that we don't expect a 50-50 split if the disease is more common among women than men. And then we also looked at whether the trials reported sex disaggregated outcomes. So in the end, we included 192 trials, and with a total of over 147,000 patients, so almost 150,000 participants, with a mean age of 61 years. Women accounted for about 45% of the participants, and men about 55%, and this gave a participation to prevalence ratio of 0.75, with a very narrow confidence interval, which shows us that there was consistency and that there wasn't a big spread. And sadly, among those 192 trials, only 39, so only 1 in 5, reported efficacy stratified by sex, and none of them reported safety stratified by sex. We also did subgroup analysis to investigate whether there were some differences between trials with different characteristics, and the only criterion for which we found a significant difference was for the main location of the trial, and this is the location of the trial, not and where the patients are based. And we found interesting that trials conducted in Europe had a lower representation of women than trials conducted elsewhere. And this may be particularly relevant to us today because we are here with the European, this tends to be a European meeting. And perhaps more important is the fact that despite some minor fluctuations, there has been hardly any change in the PPR, or the participation to prevalence ratio, over time, which shows that things are not really changing, right? And so these are our key conclusions. Women are underrepresented when we compare their participation in clinical trials for CKD with their representation in the underlying CKD population from where these patients are retrieved. And also sex disaggregated efficacy and safety outcomes are very seldom reported. So the question here is, what now? We need to improve women's participation in RCTs, and that will be the only way we'll be able to conduct sex and gender disaggregated analysis, because otherwise we will not have power to conduct those type of analyses. And this is critical to ensure that we deliver the best possible treatment to both women and men, because we definitely don't want to give certain treatment to which women or men are unlikely to benefit. And why does this matter today? This matters today because women tend to outlive men, and sadly, the prevalence of obesity is now much higher in women than men. So those are two significant risk factors for CKD, both obesity due to the increase in cardiovascular disease, and also age. So we are treating an increasing number of women with evidence based on trials conducted in men. And this is risky because women are not like men. There are biological and social factors that influence not just the physical manifestations of the disease, but also the experience of the illness that really should be taken into account when we identify the best treatment for women and men. And how can we address this? First, all scientific journals could require trials to include both sexes in adequate numbers to have power to perform sex stratified analysis. And not only journals, but also trial registration platforms should only allow trials to be registered if this is already specified in the protocol and taken into account in power calculations. Second, it's really important to ensure that the protocols promote the recruitment of women. So the practice of clinical trials needs to change to ensure that we don't have women-specific exclusion criteria, such as excluding women of childbearing age with no good reason for that, or have other nuanced criteria that may preferentially select men due to sex differences in how diseases manifest and progress. So if you require patients to be at a certain stage or have certain biochemical characteristics, that may differ between women and men. Third, it's really critical to address barriers that may disproportionately affect women in comparison to men. For instance, we know that there are gendered roles in our societies, and women tend to do the bulk of caring and homemaking. That reduces their availability to engage with research, with medical research, or they may have more language barriers or difficulty in traveling alone in certain countries. So all those barriers need to be addressed to ensure that we include a fair number of women and don't create undue barriers and disadvantage to women. Thank you very much for your attention, and I really welcome your questions and hope that we can have a meaningful discussion that will hopefully, finally, have an impact on the recruitment of women in renal medicine trials. Thank you very much.
Great, so thanks to Kat in absentia for the moment. We're hoping that she'll join us later for some discussion. So as Kate said earlier, I'm Jennifer Lees in Glasgow, and I'm going to open the discussion now just with the three of us, a small select crowd for the moment, to talk about women's participation in trials. So first I was hoping to ask Jim, an experienced trialist and has run a lot of trials in the UK, to give us his insights on the paper and the study, and really his perspective on how important is this issue.
Thanks, Jen, and thanks to you both for asking me to take part in this. Which initially I thought, what do I have that I can, shine a light on this particular topic? And you both reassured me that I would have plenty that I could contribute to the discussion. But I guess my first reflection, which is an honest reflection, is that, that the paper and that talk make me feel a little bit uncomfortable, actually, that I've not thought about this as a topic more than I have in the past, and I've been in that situation before when we talk about inclusion in clinical trials, whether that is to do with sex differences or age differences or gender or ethnicity differences. it's one of those things again. It just sort of makes me sit slightly uncomfortably, and immediately I think back to the clinical trials that I've been involved with, and think to myself, you know, have I been a part of that problem? And one of the things that stood out to me, I think, the most, it is the women-specific exclusion criteria from trials. I can't think that I've been involved in a single trial where the exclusion criteria haven't involved something about pregnancy or contraception or being a woman of childbearing age, for example. And whilst that makes sense from a physiological and a safety point of view, it is immediately then making it more challenging for fair representation, equal representation of women in those trials. And you think, well, how do you get around that? I guess we can talk about that, but I think there are definite gender-specific exclusion criteria. And then the other thing that really stood out for me from the talk was around those societal norms of kind of gender roles. And I remember seeing a program about, it was actually around towns, the design of towns around the grid system in Canada. Dr. Levin's not here, so she can't comment on that, but it was very much about how men had designed towns. And so the whole design of towns, I don't know if you saw it, Jen, I don't know if you've heard about this, but the whole design around towns is for people going from home to work without any sort of acknowledgement of childcare or anything else around gender roles, around society, what is a societal norm. And I guess that I just think about how many of the trial steering committees, how protocol committees, what the representation is of men and women on those. But my sense would be, over time, of all of those studies that were included, perhaps the overall design is more through the lens of men. And again, it's just how things are then excluded because of those societal norms, and not just from participants, but also for all of the other people who take part in clinical trials, who sit on steering committees, who design protocols, PPI groups, the whole gamut, really. So that's a slightly longer answer than perhaps you're expecting, but I think that's how things stand out to me the most, around those very clear and actually quite obvious sex-specific exclusion criteria that we've all just got used to reading, but perhaps don't necessarily appreciate how important those are.
Yeah, so thanks, Jim, for that detailed answer. And just she's just appeared, so welcome, Kat. Video on and off there.
Hello.
Thanks very much for joining us. I know you had some technical glitch meant that we couldn't see until now. So thanks very much for your presentation. We watched it with interest, and I've just asked Jim to comment a bit on, from his perspective as a trialist, to what degree is this an important issue? And he was, in short, just saying that he was embarrassed wasn't the word you used, but had acknowledged that he maybe hadn't considered many of these issues as carefully as he might have done, and was becoming increasingly aware that this might be a topic that we need to be more aware of, in the whole design and setup of trials. So I wanted to pick up on something you said, Jim, about the design of cities and then the design of trials. And actually there has been, I don't remember the details, but there has been something that shows that in trials that are led and run by women, the recruitment of women does appear to be better. So it might be that there is a bit of more careful thinking about that sort of thing.
Yeah, that hits the nail on the head. I think that it's not just that there's not women being recruited to trials, it's the whole process. So it's like when you have, a bunch of men organising a congress, it's not that they're deliberately excluding women, it's just that, I can't remember the phrase you used, it was a nice phrase, like it's just through the lens of a man. So the same as if it's through the lens of a woman, it's, it's different. So I think that the key is the whole thing, isn't it?
Yeah. And the other thing you said, Jim, that I wanted to pick up on was the exclusion criteria. And Kat had kind of mentioned this during the talk, that so I think there are, in some cases, very clear sex-specific exclusion criteria that will prevent the inclusion of women, and that those often, as you say, relate to pregnancy and childbirth and that kind of thing. But there are also unconscious biases and unconscious ways in which we can exclude women. So, for example, by having the same exclusion criteria applied, whether it's a man or a woman, despite physiological differences that might mean that there are differences in EGFR, for example, or hemoglobin, which is known to be different between women and men. So I had a question for Kat then. So my question is, to what degree did you look through any of the inclusion and exclusion criteria of these trials as you were analysing them? And were you aware that there were, what proportion of them had very clear exclusion criteria that would prevent women from participating?
No, we didn't look at that. We used, because we had a huge number of trials, it was really not feasible unless you go through each of them and look at the inclusion and exclusion criteria. But this is something that is relatively well known for trials in general, that and is also historical, the exclusion of women based on women of childbearing age due to concerns about them becoming pregnant. But in many cases, it doesn't really make any sense, and it's just adopted regardless. And for instance, I have seen some that were really behavioral intervention, just with no relation at all to your being pregnant or not, but still the same criteria apply because you just get the criteria from elsewhere and apply those criteria. And if you allow me to comment on something that has been said about the importance of women as trialists as well. This morning I reviewed a paper for a journal looking at women's representation as authors of renal medicine randomized controlled trials. And it's shocking that is less than 1 in 5. And for last author, it's even less. And the situation has not really changed from the 2000s to now. And women from minority ethnic backgrounds in white predominantly countries, like Western countries, seem to be even more disadvantaged than women from white ethnic backgrounds. And this is what we call intersectionality, which is being increasingly recognized. The question for me is, where do we go from here? And it's very easy to say, oh, this is for journals to take the lead. We need some more policies. We need this, we need that. But I think before pointing fingers at others, what each of us needs to do is to think, whenever I'm making a decision, am I making a decision that somehow disadvantages women? And why is that? Particularly us in Western countries where there is pretty much gender equality in the law, although this is being increasingly threatened, as we have seen, for instance, in terms of reproductive rights. There is still a lot of gender biases and gender discrimination that goes unwitnessed. And we are born and raised in these societies and in these cultures, and how much of what we do is also due to unconscious bias. How often are we not even aware of the lens through which we look at society and lives and research and academia? It's very easy to conceptualize academia and science and publishing and trials as a different environment, but that's not the case, right? The people who are editors, who are trialists, who are peer reviewers, they are not islands. They live in a societal context and in a cultural context that influences their decisions, influences their views, influences their actions. And medicine, it's still very patriarchal. And I have been a patient for 3 months in a hospital up to 2 months ago. And you can really see how white men still take the lead and how they are respected differently by junior doctors, by nurses. They have a kind of reputation that it's never accessible to women. And why is this? And for as long as your child draws a man when you ask them to draw a policeman, a doctor, a scientist, that means we are still failing. We are still failing women. And for as long as we think that girls dress in pink, boys dress in blue, and then they play with dolls, the others play with cars, and it's just, for as long as we perpetuate this, and I'm sorry for taking a long time, and this may feel unrelated, but it's not, because this doesn't come in a vacuum, this underrepresentation in clinical trials. It follows from everything else that comes until we come to this. And addressing it will require profound changes in our societies and in our academic environments.
Yeah, thanks. So I think you're absolutely right. There's still a lot of work to be done in a lot of different areas to try and address some of these disparities. I noticed amusingly, as you were saying, boys dress in blue and girls dress in pink, that in fact Kate Stevens is wearing blue today and Jim's wearing pink, which amuses me somewhat. So I guess, yeah. So I guess, so I have done a little bit of work trying to look at representation in trials as well, using a slightly different approach. And through that, it's very obvious that we have got two kind of phases of selection for trials. So one of them is the screening period and whether people progress to randomization. And at that point, selection can be influenced by eligibility criteria. But there's a phase before that in the approach to screening, and people that are invited to be screened, or that even go through the process of being screened more carefully. And in the work that we've done in a selected population, and it wasn't in CKD populations specifically, it suggests that actually women are slightly less likely to pass screening and to be randomized into the trials, but not to a marked degree. And that suggests that maybe to improve representation, we have to concentrate on the invitation to the screening period. So I guess question for Jim is, to what degree, when you have been doing trials or running trials or being involved in other trials, is the kind of approach to selection or the invitation to selection considered in order to try and improve your representativeness of the trial population?
That's a great question, actually, Jen. So I came back yesterday from the Society of Clinical Trials meeting in Baltimore, and they were talking about screening logs and the utility of screening logs and our approach to screening. And there was a kind of a suggestion that we might approach screening in a more systematic way. And one of the sort of experts in the audience went up to the microphone. You know how sometimes people don't necessarily ask a question, they just give quite a long comment. Yeah. But it was a really, really interesting comment. And it was along the lines of, if we have a study, and it might well be, for example, that we know as soon as somebody walks through the door that they are not going to be included in that trial. And so for the example that he gave actually was, if it is a study of pregnancy, somebody walks through the door and you look and you think, well, that's a man. So this is not somebody who would be in this study, but they've been screened, and therefore should they be on the screening log? So that's a very extreme example of, screening that in many ways is is just time consuming and actually serves no purpose. But he used that to then say that that means that the entire idea about a screening log is redundant and we should just get rid of them because they're very time consuming and often poorly completed and can give us skewed information about, for example, the number of people in an entire population for whom an intervention would be suitable. And it might therefore give you an idea that because you screened so many people and you only ended up randomizing a small percentage, that intervention is meaningless, for example. So why do I say that? Well, what I say is that you can see that as soon as somebody walks through the door as researchers, we have started a screening and a process by which we are making a choice or a decision about whether somebody is suitable for a trial, even before they've got to the point of handing them an information sheet or consenting them or randomizing them. And the example about pregnancy is fairly black and white around sex differences. But what if it was something completely different to that? And is there a possibility that you would pre-screen somebody and decide that they were not suitable for screening into the trial or approaching for to give them a patient information sheet based on the things that Kat very rightly identified as those things around unconscious bias? And I think that is entirely possible. And I think we need to be much clearer around screening and pre-screening to make sure that those things are absolutely clear, to make sure that we get rid of any sex or other differences around who we might approach, because there's a definite possibility that there's unconscious bias across the board around that, which would contribute to the equity around who ends up being enrolled in our clinical trials.
Yeah.
So I think that's an extremely valid point. And I was just thinking, like, a little bit uncomfortably, like you were saying, Jim. And so quite often in our unit, what will happen is one of the research nurses will say, well, we're doing this study, these of your dialysis patients might be eligible. And that would be passed to the 20 odd consultants in our unit. And I think there's a huge number of occasions where with the best possible intentions, we're a bit paternalistic. So we might say, oh, don't ask him because his wife just died. When actually, so we've screened somebody out because he's having a difficult time in his personal life, but actually probably we should have given him or her the opportunity to decline. So maybe one of the, so obviously eligibility criteria is a whole different topic, but maybe one of the ways around this is not to be asking the person's consultant, but actually just to say, well, this person looks to be eligible for the trial, there's this information sheet, and ask the patient, would you like to participate? And then of course they attend for a screening visit, and there will be some people who perhaps are not actually eligible on the basis of that, but maybe that's a way of getting rid of at least that part of bias, because I am sure that you're right, and that happens, like I've been guilty of that, like it happens a lot.
Well, I think that's absolutely right, Kate. And you could say, well, but randomization will sort out any of those sort of unknown unknowns, or even some of the known unknowns. That's why we randomize patients. But then what happens is you can say, well, the differences between the groups will be equally randomized, but that doesn't get away from the fact then that the participants that come to that stage may be different.
Yeah, exactly.
You know, and that's true across the board. You know, we're doing a nocturnal dialysis study, and there's no doubt that people might say, that person's never going to say yes to that, so I'm not going to ask them. And you know, that's an unconscious bias. We should be asking everybody who's eligible, and I'm sure that the same would be true around sex differences. You might say, well, that person's never going to say yes to that for whatever reason. And randomization doesn't get rid of that. All you'll find is that your groups are different when you get to the end of the study.
Yeah.
Yeah, so definitely an argument for making screening more systematic. I wanted to change direction a little bit, and this is a question for Kat. So a chunk of your study was about the fact that although trials women are underrepresented in these trials. They are represented, but we're not consistently reporting sex disaggregated results. So what do you think we can do about that? Do we need to run the trials again, or do you think there's a way that we could use some of the information that's already available to improve that reporting?
One of the key things, and thanks for this question, which is really relevant. Currently, we have at the George Institute for Global Health, we have a project called Message, which is working with funders, with researchers, with lay members of the public to create a policy or co-create a policy that aims to improve sex disaggregation of efficacy and safety data, not just for trials, but for all sorts of studies, from basic studies to the clinical studies we rely on to treat patients in medicine. And one of the key aspects to get sex disaggregation, of course, is to have enough women enrolled in the trials. Otherwise, you don't have power to do sex disaggregated analysis. But this is easy or relatively easy to solve. That's why we have meta-analysis, right? That's why if we adhere to the transparency standards that have been asked for a very long time for clinical trials in particular, if the data are publicly available, then researchers who have expertise in meta-analysis can do meta-analysis and collate results from different trials and do all sorts of disaggregated analysis, because power is no longer an issue. You have a lot of patients and there is no point in conducting trials again. And this is something for funders to consider as well. And for journals, it's usually much easier to publish observational studies, trials, than to publish meta-analysis. And some people have called the people who do meta-analysis like the ones who don't want to, or don't have the expertise, or don't engage, and it's kind of the Cinderella of the research types of articles, which is actually wrong, because we can really derive useful information, but transparency is still a mirage, and we don't have really publicly available data to do most meta-analysis that we would like to do.
Yeah, so I think you're right. So I've done a little bit of work with trial IPD, which individual participant level data, which makes it absolutely possible to do the things that you describe and analyse by different, by sex and by different subgroups. But you're absolutely right. So you can generally get these type of data for a small proportion of the total trials that have been conducted, and so improving accessibility and transparency for these types of things would help improve reporting of all these types of problems. I don't see that there's any questions on the Q&A, so just a reminder to the audience that they can send questions into us and we will try and ask them. Otherwise, Jim's got a question. Yep.
I was just going to come back to something that Kat said earlier around, how can we change the sex mix of people who are involved in research, that women are clearly underrepresented in medicine and doing clinical trials, especially in renal medicine. And I remember somebody saying to me once, that actually what we do in an unconscious way is that we tend to perhaps give opportunities to trainees and early career researchers who reflect the journey that we've taken in our own careers, because you potentially just connect with those individuals more because they represent the journey that you had through your career. And this was in the context of somebody sort of looking at my research group, which actually at the moment in my study team for a couple of, I am like this panel, the lonely man in that, and saying what is it that's slightly different, Jim. And I kind of look back and think I like to be challenged, as opposed to just having people around me who agree with me all the time because that's easy. But I think there is a danger that you offer opportunities to people earlier on in your career. How about writing up this case study? And then as people progress through their careers, because they've had those opportunities, they potentially stand out a little bit as they get to more senior research. And then that sort of propagates the problem that they're offered then more opportunities and therefore get more experience and build their CV and then get more opportunities and so on. So I was just going to say, I think we need to be very, very careful about the opportunities that we offer to early career researchers and people much earlier on in their careers, to ensure that we are giving equal opportunity to everybody, so that when we get to the point where we need PIs and much more senior researchers and clinical trialists, that reflects a much broader spread. And I guess that's what I just wanted to pitch in from the conversation that came up earlier, that we need to be thinking about this much earlier and giving opportunities much more fairly and broadly to trainees and people earlier on in their careers.
Yeah, so I think that's really true. And so that I've done stuff on a few of the committees within the European Renal Association, and I always think you should have people doing things because they deserve an opportunity, but also because they're good. So you shouldn't pick somebody to do something because it's a woman. So you shouldn't ask me to talk about clinical trials when Professor Burton is there, because Professor Burton knows more about them than me. It doesn't matter that I'm a woman. And I think that one of the difficulties is that getting like some of the organizations and the journals to understand all these nuances that you're talking about is quite difficult, because what you find, I think, from having been in some of these committees, and you'll all have the same experience in different places, I kind of find that people say things like, oh, well, people are making a fuss because there's a manel, so there's four men on this panel and there's no women. But we asked 5 women and they all said no. I'm sorry about my dog. So I kind of think that they missed the point then, because there must be a reason that the 5 women that they've asked have all said that they won't do it. But I think often we don't explore those reasons. So why are we not looking at why people are not taking part? Why are we not looking at why we're asking specific individuals and not others? And what are we doing to try and make it easier? So, things like different congresses and meetings will say, oh, well, we've arranged a breastfeeding room, so that should make it easier for women to come who are breastfeeding. But I suspect if you ask the women who are breastfeeding, which they often haven't done, they've just gone ahead and set this up as a concept, and it's obviously great. I'm not dissing that as a concept, but they perhaps haven't asked the people that are going to be using this room about what they need in that space. And so therefore people who are breastfeeding don't come and don't use the room because there are problems with the room that people who are not breastfeeding haven't thought about. And I think that's true on almost every level in this kind of conversation, that we just don't ever really get to the root of it, because, and I do think genuinely there is good intention and people want to include everybody in trials, and they want to include everybody talking at congresses and writing papers, but there just seems to be this lack of considering, well, what is it that we're doing that's not allowing these people to take part? Because just saying, oh, I invited them and they said no, isn't really the answer in my opinion.
And reassuringly, there are some people looking at behavioural aspects of, how we set up trials and how we invite people to trials and that kind of thing. So hopefully some of that work will be done in the coming months and years. Kat?
I was going to echo what Kate said, because I've been organizing a lot of events and it's a real struggle sometimes to find women to come to the meetings. I don't know why, and but it's really difficult and it's not just about children. Some of them, or many of them, are no longer childbearing age. but still struggle to commit. And I wonder whether it is because teaching pastoral roles tend to fall more on women than on men when it comes to researchers. But the same thing applies to participants in trials. If we were to publish, you see, when you see the consort diagram with the trials and the arms, it would be really interesting to see how many of those that dropped off at each point, starting again with run-ins and screening, etc. How many of them are women and men? Those things would be really good to guide policy in terms of requirements, etc., for publishing and registering clinical trials. I think that would be a really big step forward in this direction. And I would also like to echo again what Kate said in terms of quotas and positive discrimination. That's not what we should be aiming for. What we should be aiming for is to have women at the same stage, with the same skills, with everything in similar conditions to apply for everything as men. And that's not the case, because it's like the leaking pipe, or whatever you want to call that. At each step, women experience disadvantage, and then it gets to a stage that women start falling behind because there are all these glass ceilings that they can't breach. And then when you come to, for instance, selecting people to becoming senior editors or whatever, or professors, where they don't have the same career because at each stage they were disadvantaged, they had to fight harder, and those things then reflect on their CV, and they can't reach their full potential. So we really need to start with young girls and then remove barriers on a steady manner to ensure there are really no stumbling blocks that prevent women from reaching to where they can get to.
Yeah, absolutely right. So I think, unless anybody's got anything else they particularly want to say, we'll wrap up just now. Kat, anything more you'd like to add? No. Jim, anything more you'd like to add? No. Kate? Lovely. So I would like to say as well, this is Kate and I, this is our last ERA Journal Club. We're handing over the reins to Andreas Kronbichler to take over, and Will Harrington will continue as before as well. So just like to thank today Kat for speaking, Jim for being an expert panelist, and everybody for the I think really interesting discussion that we've had. Thanks to the ERA for organising, and to all the participants for paying attention. So we'll see you next time. Thanks a lot and enjoy the